Hello everyone, I am Dr. Sudha Mukherjee and today I'll be talking about chest x-ray, its basic view and approach. So chest x-ray is an important aspect of medical examinations where we can see a lot of structures through chest x-ray and through its different view and can diagnose a lot of disorders. It's a kind of now basic and primary mode of investigations, although one of the most important examinations. So before we start, I would like to say a few words regarding the relative densities because we all know about the chest X-ray, its invention, and how the chest X-ray is being originated from the collimator X-ray beam and how it is recorded. But the basic principle behind is that the images seen on a chest radiograph results from the differences in densities of the materials in the body. The hierarchy of the relative densities from least dense black to most dense white is in this order: the gas, that is air in the lungs, then fat layer in the soft tissue, water, the same density as heart and the blood vessels, then bone, the most dense of the tissues, and metal, any foreign bodies. So before interpreting any radiograph, these are a few of the important aspects that the must is the patient identification because this is one of the most important. Second is different types of X-ray view, whether it's a PA, posterior anterior, or AP, or lateral, or any decubitus view. Then the breadth, whether it's an inspiratory film or an expiratory film. Then the X-ray penetration, it's under penetrated, over penetrated, and whether the positioning has been done in the proper, whether there was any rotation or not. And after the basic thing is done, we'll go to diagnose different types of disorders. So the four major views of the chest X-ray is that the PA view, that is we call posterior anterior view. Second is your lateral view. Third is AP view and the lateral decubitus view. So PA view, the standard position is the PA view for obtaining a routine chest radiogram, and patient stands upright with the anterior of the chest placed against the front of the film. The shoulders are rotated forward enough to touch the film, ensuring that the scapula do not obscure the portion of the lung fields. Usually taken with the patient's full inspiration so that we can see more of the lung fields, and the PA film is viewed as if the patient is standing in front of the view. So this is how the chest X-ray PA view is obtained. You can easily see that the position of the person who is standing with the end of the chest touching the X-ray film, and the widening of the mediastinum so that the scapula rotate outside. And this is how the PA view of chest X-ray looks like in the right side of the screen. You can see the trachea, these are the lung fields, and this is the heart shadow, cardiac shadow, these are the ribs, and this is how it overall looks like. So second is your AP view, anterior posterior view position, and it is viewed when the patient is debilitated or immobilized or in supine posture and cannot stand. And in that scenario, most of the ICU conditions where the patient is admitted in ICU and cannot be moved, in that condition also you take AP view. So film is placed behind the patient's back with the patient in a supine posture. Heart is at a greater distance from the film, hence appear more magnified than the PA view, and the scapula is easily visible in the lung fields because they are not rotated out of the view as they are in the PA view. So these are the few of the important facts. By also you can examine a film and can say that whether it has been taken in a PA view or AP view. So this is how the X-ray collimator is projecting over the entire aspects, and patient lies in a supine posture, and this is how it is again in a sitting posture, and this is how the AP view looks like. You can see a magnified view of the cardiac salute, and these are the lung fields. So this is how the AP view looks like. So the basic difference in PA and AP view is that in the PA view, the seen in the periphery of the thorax and the scapula, and the AP view is seen over the lung fields. So clavicles projects over lung fields, above the apex of the lung fields, and ribs, posterior ribs distinct, anterior ribs are distinct. So this is how you can differentiate between PA view and AP view. You can easily see these two chest X-ray and can easily diagnose. Now coming to lateral position, the patient stands upright with the left side of the chest against the film and the arms raised over the head, allows the viewer to see behind the heart and the diaphragmatic dome, typically used in conjunction with a PA view of the same side of the chest to help determine the three-dimensional position of organs as abnormal densities. And this is how it is done in the lateral position. And lateral decubitus film is that the patient lies either on the right and the left side. The standing position of the regular radiograph. The radiograph is labeled according to the side that is placed down. The left lateral decubitus radiograph would have the patient's left side down against the film. So often useful in revealing a pleural effusion that cannot be easily observed in an upright view since the effusion will collect in the dependent location. That is the favorite question in the examinations also. Which view is the most important for looking into the pleural effusion? So this is how it looks like. You can see easily that the dependent persons can see the effusion. So these are the one of the most important views in cases of chest X-ray. Now coming to the main factors that detects a high quality of the chest X-ray is the inspiratory film, the penetration, and the rotation. So inspiration is that the chest radiograph should be obtained with the patient in full inspiration to help assess the intrapulmonary abnormalities. In full inspiration, the diaphragm should be observed at about the level of 8 to 10 rib posteriorly or the 5 to 6 rib anteriorly. This is how it looks like. So if we count the ribs from down, this is the first rib, the second rib, this is the third rib, this is the fourth rib, this is the fifth rib, and this is the sixth rib. So this is the sixth rib in full inspiration, and in the expiratory film you will be seeing a less because the lung is not expanded so much. In cases of penetration is also very much important to determine a good quality X-ray. On a properly exposed chest radiograph, the lower thoracic vertebra should be visible to the heart, and it is just visible actually. The bronchovascular structure behind the heart should be seen. So in case of underexposed, the chest radiograph, the cardiac side is opaque and you cannot see this structure that is normally should be seen. So this is how you can define a good quality of X-ray also. And this is how an overexposure of film can be. So this is an underexposure, you can see the more of the opaque, and this is overexposure, you can more of the black, you cannot see these behind these bronchovascular structures. So with greater exposure of the chest radiograph, the heart becomes more radiolucent and the lungs become proportionally darker, and it often gives the appearance of lacking lung tissue. So you would be falsely diagnosing as in case of emphysema, although the condition is due to overexposure. So the penetration is one of the most optimum factors to be at the same level so that a good quality X-ray can be interpreted. Now coming to rotation, rotation is often we neglect, and that results in kind of misinterpretation. Patient rotation can be observed by observing the scapula as well as the clavicular heads, determining whether they are equal distance from the spinous process of thoracic vertebral. So this is the clavicle. You can see the same distance from the center, not this sternoclavicular head, or are in the different distance like in this picture. So basically the patient has been rotated when the chest X was taken. So it should be in centered equal distance between medial and the clavicle and the midline as here. It should not be like this where some of the persons are greater than the left side. So angulation and rotation is one of the most important factor, and otherwise it will be very difficult to interpret the mediastinal shift, and some other diagnostic dilemma will be there. So angulation and rotation, these both are very important. So review of basics, that's some of the important factors. Now coming to approach, in order to recognize the abnormality, you need to know what a normal chest X-ray looks like. The chest X-ray on the next slide is normal. How do you interpret it? That is the question that you should know first of all. So this is an X-ray, how it will interpret. So you can see the structure, then you will diagnose as an algorithm that we do have from A, B, C, D, E, F, that I'll be talking a little bit. So this is A, B, C, D approach of chest X-ray. A for airway, B for bones and soft tissue, C for cardia, D for diaphragm, E for effusion, esophagus sometimes, F for fields, the lung fields, D for gastric bubble, then H for hyaline mediastinum, and I for impression. I can go ahead with till Z, but however these are one of the most important factors for the basics of chest X-ray view and how we should approach. So this is the airway. We will see whether the trachea and the bronchus are in the same condition as the normal chest X-ray. So this is, you can see the radiolucent structure is trachea. This is the left main and this is the right main bronchus, and this is the carina where it has been divided. This is the schematic diagram, and you can see the right upper bronchus also a little bit. So this is how a normal chest X-ray looks like. But if there is any deviation, then it can be easily understandable whether it is more deviating to any sides or it is not visible or any other signs. So this is about the airway. Coming to B for bones and soft tissue, you can see the ribs, whether any fracture or not. Is there any destruction? Is there any more opacity? Any other deposit? These are the ribs, these are the clavicles, these are the vertebrae. So look at each rib in turn, the clavicle, scapula, and other bony structures. So and this is how you can diagnose any bony abnormalities also in cases of chest X-ray. So coming to soft tissue, thick soft tissue due to obesity may sometimes obscure a good quality images, and breast tissue shadow may be overlapping sometimes. You must be cautious before interpretation, and loosens within soft tissue may represent gas as observed with the subcutaneous ear. We have seen in cases of subcutaneous emphysema where you will see the ear shadow. So these are the soft tissues, the supraclavicular fossa, the enlarged nodes, lateral chest wall, surgical emphysema. These are the places where you should look for, and under diaphragm, whether any gas under diaphragm, pneumoperitoneum or not. So these are the importance. Now coming to one of the important factors of subcutaneous emphysema, this is how it looks like. You can see the air inside the soft tissue. This is a typical picture of subcutaneous emphysema, and you can see the gas under diaphragm beneath the right dome. So basically, this is the pneumoperitoneum where the gas under diaphragm, and this is an emergency. Coming to C for cardia, the two-thirds of the heart should lie on the left side, as we all know, and one on the right. So the heart should take up less than half of the thoracic vertebra, and cardiothoracic ratio should be less than 50%. Otherwise, we call it a cardiomegaly. The left atrium and the left ventricle create the left heart border. The right border is created entirely by the right atrium. The right ventricle lies anteriorly and therefore does not have any border on the PAV. This is one of the important questions that you can be asked. And you should remember that the RV, right ventricle, never comes in the right border of the heart. So this is how it looks like. So these are the structure. This convex is the aortic knob, aortic knuckle. Then you see the main pulmonary artery, we call it pulmonary bay. Then is the left atrium, the left atrial, left auricle or left appendage. Then the left ventricle, and this is how the left border is. On the right, there is superior vena cava. Then the right atrium, as a whole, is comprising the right border. And if we see in the left lateral view, then this will be changes. This is the retrosternal space, and mostly formed from the right ventricle. If this is obliterated, then most likely it is right ventricular pathology in form of right ventricular hypertrophy. So this is how the aortic knob looks like. You can see in any normal chest X-ray, especially in elder individual also. This is quite prominent, and this is called left window, and the pulmonary artery, the pulmonary bay, and the left atrium, left appendage, then the left ventricle. So this is how the left border of the heart, and this is the right border of the heart. So, and how do you measure the cardiothoracic ratio? The CT ratio is very important. From the midline, we extend to the highest maximal convex point on the right side as well as the left side. It must not be in the same line. It may be a different line because we measure from the maximum convex point. And as a whole, this sum of this right side and left sided the length should be divided by as a whole, the whole length of the thoracic. You can measure here, and then we divide, and this is how the cardiothoracic ratio is obtained. It should be less than 50, less than 0.5 or 50%. So this is how the cardiomegaly is being described in case of chest X-ray. This is the main March effect that I will not be talking because this is a very advanced case. So coming to D for diaphragm. Diaphragm is one of the most important. We all know that these are the diaphragm. In case of it separates the chest from the abdominal cavity, and both diaphragms should form a sharp margin with the lateral chest wall, and both diaphragm contours should be clearly visible. Normally the right side is 1.5 above from the left, and you can see the gastric bubble in the left side. So this is how you should be looking into the diaphragm. If there is any much at a higher level, then there may be any pulse, any of the abnormality. Sometimes liver abscess may push the right side above, or sometimes any other pathology may obscure this portion of the diaphragm. So D for diaphragm, it is very much important, and cases of diaphragmatic hernia, in cases of other pathology. E for effusions, the pleura and the pleural spaces will only be visible, as we all know, when there is abnormality present inside that cavity, like in the form of water, pleural effusion, or any other hemorrhage, or any other things like chylothorax and or air in case of pneumothorax. So these are the lung field. Normally we do not see any effusions, but if there is an effusions like this, you can see the left side is totally obscuring the lung field, and this is a large pleural effusion. In the almost whole, the right side is like this. Here in the left side is obscured. Here there is a hydropneumothorax, and here this is the right middle portion is kind of phantom tumor, we call it. So this is how the pleural effusion look like. In cases of pneumothorax, like here, you can see the blackish shadow, like looks like overexposure, but the same field you can see the lung markings that differentiate between that this space is totally of air and this space is totally of lung markings. So this is the you can call it a pneumothorax, where the air is inside the pleural cavity. So coming to F, the lung fields, this is the most important. Normally there are visible markings throughout the lung parenchyma to the pulmonary arteries and veins, containing all the way to the chest wall. Both lungs should be scanned properly, starting at the apices and working downwards, comparing the left and right lung fields at the same level. So these are the lung fields. We can divide in three zones: upper zone, middle zone, and lower zone. And on a PA radiograph, the minor fissure can sometimes be seen. However, it is very difficult to find unless under patients in heart failure most of the time. So we can see a lot of features of different pathology in that lung field. In cases of pulmonary venous hypertension, we can see interstitial edema. We call it curly B lines. In cases of lower consolidation with pneumonia, we can see different types of consolidation involving different types of lung zone. And in cases of some other hyla age, you can also see some other important markings, sometimes prominent pulmonary artery. So this how looks like. This is an extensive aspects of approach to chest X-ray and different cardiovascular as well as respiratory pathology that you have to learn over a long period of time by learning, by seeing chest X-ray and at the same time reading the textbook. However, these are the basics of approach of different views of chest X-ray as well as in different aspects of chest X-ray that we can describe. So this is how it looks like. The G is for gastric bubble. It is in the left side, so the situs solitus we call it, because sometimes you can see in the right side also in case of any extroversion and situs inversus. So H for hilum and the mediastinum. This is consist of the primary, the major portion, the bronchus and the pulmonary veins and the arteries. And the hilas are not symmetrical but contain the same basic structures on each side, but maybe at the same line, but the left arm is commonly higher than the right. Both hilar should have similar size and density. So this is the right hilar point, this is the left hilar point. And coming to another aspects of pulmonary artery branches or vein branches that can be visible in different disorders. And you can easily diagnose these conditions by the lacking of these normal vascular or normal effects of bronchovascular markings, that it can be pulmonary oligemia, but the less blood flows in cases of some congenital heart disease, whereas it may be pulmonary plethoric where more blood flows in cases of heart failure. So these are the different kinds of scenario that looks like different types in chest X-ray. Sometimes it's very much plethoric, sometimes it's oligemic. Come to mediastinum, the trachea should be centrally located, as I have told initially, and how it may be deviated in cases of some mediastinal pathology. It may be pushing to the right, it may be pushing to the left. That also depends on the pleural cavity effusion or some other like collapse consolidation. So this is the normal chest X-ray again, where this is the cardiac salute. This is the ascending aorta originating from left ventricle, coming to aortic knob, and then coming as a descending aorta, and with the paratracheal vessels that we can sometimes diagnose in the chest X-ray. So this is the mediastinum. Again, we can divide into upper, lower, superior, inferior, and anterior, posterior, middle mediastinum. And depending on that, there are various structures. These are very important, and that can give a significant salute sign in different disorders. So in cases of ICU, as I have seen, and I have told you that the AP view is the most commonly, so this is one of the AP view, and sometimes we can see some other structures in cases of ICU where we can see some other, like sometimes the patient is on central line, you can easily recognize, sometimes patients on ventilator you can see, and sometimes some other structures which are somehow confoundedly attached, then you can see. So these are some foreign objects also you can see whenever you are seeing any ICU. So coming to problem solving tools, always look into the previous chest X-ray if it is visible, because we can compare in that scenario whether it was situated previously or not. These are the most important factors. Identification, the same patients or not, and the right side, left side is one of the important aspects whenever we are diagnosing something. But the basic algorithm of ABCD should be kept in mind before we are going for any diagnosis. Remember, the diagnosis is can be delayed because we do have some other investigation in our hand, that the basic approach can guide you regarding which direction we should go. This is one of the most important aspects of chest X-ray. So there are a lot of signs by which we can diagnose a lot of disorders, but so far it is important to look into the lung parenchyma as well as look into the pleura to diagnose some important common disorders. And with cases of trauma, we should be looking into the ribs. If a rib abnormality is suspected on clinical grounds like trauma, So before deciding that the ribs are normal, rotate the image through 90 degree and assess the ribs in the second position. Then turn the original image through 180 degree and evaluate the ribs in third position, because the minor crack or minor fracture often miss. So this is the important point regarding in cases of patients who are coming with trauma. And apart from that, the soft tissue and any other mass lesion should also be clearly visible in a good quality chest X-ray. Before commenting to any respiratory pathology like emphysema, you should be cautious regarding the overexposure regarding chest X-ray. So this is how we should be looking into chest X-ray whenever we are interpreting chest X-ray. And with this, I would like to conclude this session. But before we conclude, remember one thing again, that the inspiration and the expiration, these are the two aspects of any chest X-ray. So right side is inspiration and right side is an expiration. You can easily diagnose the more lung fields and the less lung fields. The cardiac salute of side is normal, but it is a kind of magnified view. Second is a penetration. Again, this is a penetration is overexposure. This is a normal. And so this is one of the important. Then foreign body, if it is, then it should be compared with previously. Then soft tissue, any other metastasis, any other extra mass, that should be good. And whenever the X-ray is looking normal, look in the second time before commenting it's normal, because diagnosis of normal chest X-ray is one of the most difficult, because we have to exclude so many things. So go by the algorithm of A, B, C, D, E, F, G, H before diagnosing this is a normal chest X. And always remember that the chest X is not about diagnosing, it is about guiding you, because we do have a CT scan and other advanced investigation by which can diagnose confirmly. However, chest X can definitely guide you regarding which investigation you should be looking for. And with this, I would like to today to take home message that the look carefully for patient identification details and technical issues. Be systematic in approach. It's a chest X-ray, not a lung X-ray. So you can look a lot of things apart from the lung pathology. Concentrate on hidden areas and compare with the old films and lateral films before concluding your remarks on the chest X-ray. So with this, I would like to conclude today's session, and I hope that this short session on approach to chest X-ray helps you to understand the chest X-ray in your future. With this, thank you very much.